We need a culture shift in heart failure care. I think the scientific evidence now, especially post-strong HF, is overwhelming, supporting that rapid sequence simultaneous initiation strategy, as done in strong HF, is safe and effective and will lead to better patient outcomes and improved use of GDMT. I think we need to recognize the risks of omission with delaying our therapy. We're so used to thinking about when you talk about a new medication with a patient, one of the common things that comes up might be, well, what are the side effects? Yes, you need to talk about potential risks of safety and tolerability that are theoretical with any medication change you make for any reason. But with our heart failure medications, you also, to be fair, we need to talk about the risks of omission, the risks of delaying those therapies. The risk of not starting the therapy is higher risk of passing away, higher risk going to the hospital, higher risk of symptomatic deterioration. So I think really framing these discussions in risks of omission can really be very helpful.
And there are many surveys done in many chronic diseases, including heart failure, that if you ask the patients what they want from healthcare system, it all boils down to one thing. Patients want to be independent. They don't want to die. They don't want to come to emergency room. They don't want to have 100 clinic visits. They don't want to go to nursing home. They don't want to go to, they realize that with chronic diseases, there are some limitations, but as best as they can live with their quality of life, functional capacity, be independent. And the only way we can deliver that is to give them the appropriate medical therapy, because that's give them the best shot. The question is whether you can scale strong HF results in your setting with your patient population. Will the healthcare system have enough resources that is put into to implement this and implement it safely? And I actually can understand what they are saying, and that is that it's a good idea to implement strong HF protocol. But remember, strong HF protocol had two parts: implementation of therapy, but a follow-up for safety and just make sure that everything is going okay. And I think if you only take one lesson of implementation, but not have a team effort to make sure that everything is going okay, then you have a potential of actually, harming, because even if you have one bad experience, that clinician is not going to do that for any of their patients, right? So you are to just certain to make sure that you follow the entire protocol, both the safety and the efficacy.
And so I think first is appropriate patient selection. And the second thing is to think about the risks of not acting. We've seen repeatedly the risk of not acting is high. We know that many of these therapies have rapid benefits within the first 30 to 90 days of being started. And so we often focus on the risk of doing something, but there's equal, if not greater, risk of not doing things. And I think that's one of the things that Strong HF showed us, is that the risk of aggressive medical titration of multiple medication changes at once is in fact small compared to the risk of not making these changes for our patients.
There has been establishment of guideline-directed medical therapy clinics. This is like a relay race where the GDMT clinics will take the baton from the inpatient side and continue aggressive titration of guideline-directed medical therapies with an express goal of getting patients on all of the indicated heart failure therapies and getting them to target as soon as possible. The goal, therefore, is not only to ensure that the hospitalization discharge was safe, but also to get patients to target as soon as possible with a goal to improve their prognosis and improve their health status.
One, you provide good care to the patients, and that's our number one reason why we exist. Having said that, there is actually a direct financial benefit and an indirect financial benefit. The indirect financial benefit is that if you can avoid these hospitalizations, then everybody is running short on beds, and then you open up beds for other things like scheduled surgeries, which we routinely cancel because the hospitals are full. And then the third is that the Medicare penalties are like 1, 2, 3% of all Medicare payments, which is way more than what it would take to implement strategies to avoid these high readmissions in the first place. So I think there is a direct financial gain to be had, an indirect financial gain to be had, and it's just the right thing to do.
Heart failure has a prognosis comparable to many cancers. When you say the word cancer to a patient or a clinician, There's this sense of urgency. There's like, okay, you're feeling fine today, well, we gotta think about longer term. Let's get you on therapy, let's get you tested for all the various things, let's get things up and running for you. Heart failure, again, same prognosis. We need to think about it with the same mentality though, that sense of urgency. Gotta take it seriously. You have a patient in front of you, now's your opportunity to get them on the proven disease-modifying therapies, including making more than one step at a time. The serial selective approach of making one move today, see you back in 3 months, that's not gonna cut it. And you see what that gets us in the CHAMP-HF registry, for example, where patients remain on stable sub-target doses indefinitely or no medications at all. Meanwhile, they're having high rates of death and hospitalization. It's just not gonna cut it. And I think now with STRONG-HF, we have more direct randomized clinical trial evidence, again, overwhelmingly supporting the safety and efficacy of a rapid sequence simultaneous approach, and also recognizing that with usual care, those risks of omission resulted in even the Data Safety Monitoring Board saying they had to stop the trial early. So the message of STRONG-HF is the sense of urgency. We cannot wait for only in-person clinic visits, which are sometimes hard to schedule only every 3 months or 6 months in some clinical practices. We need to take advantage of a need for speed mentality. And that's where I think the remote or virtual visit can be so instrumental. There's been some studies that have already looked at this, showing that it's feasible, safe, results in further augmentation of GDMT. And I think coupling that remote virtual visits with the serial laboratory monitoring, including natriuretic peptide testing, can give potentially clinicians who are maybe a little hesitant up front about a remote virtual strategy to make medication changes with, couple that with natriuretic peptide testing, patient symptoms, and basic metabolic panel to ensure potassium and kidney function are okay. I think you're really building a case for a lot of reassurance that yes, you can make medication changes remotely, and that overall it's gonna be a very safe, practical, patient-centered way for your patients to get on best therapy.